Thank you to the Anaphylaxis Campaign for inviting me, and thank you to you all for coming along and attending this morning. So my name is George. I am a pediatrician and an allergist. I work down the road at St. Thomas's Hospital, and my university is King's, which is firmly based in this region, really. It's got lots of offices and buildings all over. I am riddled with conflicts of interest. So I receive money for research into peanut allergy, which is mainly from American government, the NIH, no conflicts there. I receive money from FAIR, which is like the patient support group in the States for our research, from the National Peanut Board, which is, supports our research unit where we do our trials. I've received grants from various bodies. The ones you may be interested in is Food Maestro, which is an allergy app. I have very small interest in that. And I am running 3 trials. Immune, you can see they are co-sponsors today, is a commercial company looking at peanut desensitization. So if any of those concern you, take what I say with a pinch of salt. I have a topic called What's New and What You Should Know. So I'll try and put some new slants onto existing data, and I will also try and emphasize what I think you should know, which will come with some bias. So I'll try and cover various aspects. I'll mainly talk about 2 phenotypes of peanut allergy. So those are 2 ways you can become allergic to peanut. The most obvious is what most of you are familiar with, which is when you react to a peanut with your first or second exposure as a young infant, usually in your first or second year of life, and that stays with you for life, and that has the potential to cause severe reactions. That's very well understood by most people. What is less understood, and I'll show you some new data, is the child who eats peanut when they're younger, they then develop birch pollen or grass pollen sensitivity, and then start going off peanut as part of the oral allergy syndrome. And that's a milder variant of peanut allergy, and I'll show you some interesting data around that. I won't cover treatment or briefly with epidemiology. We know that food allergies have increased. And there's good evidence, particularly around peanut, and it continues to increase. So even though we have the LEAP study findings, which is a highly effective way of preventing peanut allergy, there's an 81% protective effect in high-risk children if you eat peanut early, and I'll show you that data. That is as powerful as many vaccines, just through eating a healthy food. The problem is applying that to a whole population, reaching the populations most at risk. So practically, it's a very hard intervention to get across, and I'll discuss a bit of that. So those are things you should know about. Today I see on the topic people will also be covering the burden of disease, and there's a very necessary emphasis being put on the burden of living with this disease. There's a cost associated to eating free from foods, time and logistics. It takes a lot longer to shop, and if you're like me, you may need reading glasses to read every second label. There's an emotional cost. As a parent, you live in fear, and I see parents, some absolutely crippled with fear as to what may happen to their child. And there's a sort of second wave as the child moves into adolescence. They are really worried their kids are going to go out and willingly eat their allergens. And I just don't see that. I take great pleasure in reassuring parents that young Johnny, even if he's had 3 beers, is not going to grab a handful of peanuts willingly. I haven't seen a teenager willingly do that. Of course, the chance of an accident goes up as you get a bit older and they're no longer eating in your kitchen. But nonetheless, there's a burden of disease, emotional burden associated with that. There are nutritional consequences to being food allergic. By and large, if properly managed, as Sarah said, if you get into the right hands, allergic kids often have a much healthier diet. You just cannot eat confectionery off the shelf and the rubbish that most kids are exposed to. The kids, certainly during the early life, will often grow up eating home-cooked foods and foods that are safer and generally healthier. And I'd also just like to cover accessing support. So obviously, this is one of the 2 patient support groups in the UK, but it's important we support them so they can support our patients and us. So what is new? So as many of you know, we've got a mixed knowledge audience today, but as many of you know, the gold standard, the most rigorous form of scientific evidence is a randomized controlled trial, where you put children randomly into one of 2 arms where there's an intervention, and then you then measure this over time. Now, there have been pitifully few RCTs done with regard to food allergy prevention. in the last few years. They are now coming out. This may look like a long list, but if you compare this to cancer or diabetes or other chronic illnesses, we are really underfunded and underscienced in this field. So the LEAP study, which I'm very proud to have been part of and extremely grateful for those who offered up their children and their time, family time to partake in this, showed the most rigorous result, and I'll go over that. The other study with regards to egg is a Japanese study. That's the only other trial with food allergy that has given a result in the intention to treat group. So this is a scientific term, but it's important you understand it. If you analyze an intervention, you should really analyze. The most rigorous way to look at it is if you look at the two groups and everyone you intended to treat. So even if you fail or you don't follow that intervention, you still get looked at the end of the study. So it's a very rigorous way of looking at a trial. If you just look at a per protocol outcome, it's a very biased way of looking at a study, particularly in this field. So for example, if you look at peanut allergy at 3 years of age in children where peanut was the intervention, and you find no peanut allergy at 3 years in the per protocol group, does that mean that peanut allergy, eating peanut actually protected them? Or was there some kind of bias that if you couldn't follow the protocol, you just fell out that group? So you fell into the ITT group and you came out the per protocol group. And it's a technical issue, but it often confuses the way people assess trials. And I'll cover the EAT study. So our old friend peanut. For quite some time now, we've been trying to learn about these proteins, and an innocent old peanut, a pea, a legume, a pulse, grows under the groundnut, a monkey nut, a groundnut. We've been trying to learn about this, and why do these proteins cause us such mischief? And we now can identify these proteins, and we know a lot more about them. There are many, and there's probably a really small handful that cause mischief in humans, mainly this ARA-H2 protein. The ARA is Arachis hypoglossus, so the Latin name, and 2 is the protein that causes you mischief. And then this milder variant of peanut allergy is caused by this ARA-H8 protein, and then in parts of Europe, ARA-H9, it's a lipid transfer protein, cause you some mischief. So we've long been studying this now, and if you look back at the LEAP study, our proposal first went in 2004. We started enrolling around 2006. We are now in 2017. We have managed to publish on an annual basis various aspects of the study, and I'm very pleased to show you just a few of these today. And so this is basic knowledge that if you're working in the field, you probably want to know about. So the LEAP study was extremely simple. They were at-risk infants. They either had egg allergy and/or eczema. The intervention was eat a lot of peanut or eat no peanut. Parents amazingly did what we asked them to do, and we had various ways, if you've heard this morning, of trying to assess if they actually were telling the truth when they said they either ate or avoided peanut. And we followed them up to 5 years of age. 5 years is a good interval to follow peanut allergy, because if you are going to outgrow it, which very few children do, that will generally happen in the first 5 years. So you allow for the natural history of the disease to play out whilst you're making a scientific assessment. What did we show? Well, if you sit back in children in the UK, at-risk children, and you do nothing, in the avoidance group, some 13% will land up with a chronic, potentially life-threatening disease. So that is no longer an ethical approach, in my opinion. We need to intervene early, and this advice is now filtered through to many societies and to parents. In fact, it's extremely reassuring in clinic on a daily basis. Peanut no longer scares nursing moms or moms of young infants. They often come to me and they want to know about other allergens. And they'll tell me, do you know, you should really introduce peanut early in life. It's a very good thing. They've read this somewhere and they start lecturing me about the LEAP study. And it's amazing that parents know this. It's out there on social media. And peanut no longer scares moms with regards to early introduction. There are a few who are still anxious and need support. If you intervene, you can get this right down to 1.9%. So that's a staggering reduction, 86%, through eating a healthy foodstuff. This is not a drug, it's not an injection, it's not a vaccine, but it's extremely immunogenic. People then started asking after the 5 years, what if children stop eating peanut? What will happen to their tolerance? Will that fall off? So what we did on the LEAP-ON study is we took everyone, the previous consumers and avoiders, and asked them to avoid peanut for another year. Now, this was a really big ask because you need to go to families, some of whom have enjoyed an obvious benefit through eating peanut, introducing it for their child, and saying, do you mind stopping this for a year to see if we can undo the benefit? If this benefit is a transient benefit or is it sustained? Is this a treatment, like taking a statin or a drug every day, that if you stop taking it, your cholesterol will come up again? Or is it a cure? Have we silenced the gene? And so after an additional year, you can see that the numbers change slightly for technical reasons, the way that the outcomes are measured. But overall, a group of 640 children, you'll see that you still enjoy a massive relative reduction, a benefit through early introduction of peanut as opposed to avoidance. So that is a very strong effect. You can analyze this in using whatever statistical model you want. In fact, you can use a worst case imputation. You'll seldomly ever see this. This is boasting, but I'm just trying to stress that this is a robust finding. If you take people that weren't present at the end of the study and you put them in the wrong group, so you make them work against your hypothesis. So if you say that eating peanut was going to cause allergy, and we suspected that it wouldn't, even then you still show a benefit. Even if you try your hardest statistically to make this trial fail, it does not. And the reason you can do that is there were very few people that didn't stay on the trial till the end, which is reassuring as well. So this is acceptable. What's important to look at is up in the top left block, you'll see skin prick test negative and IgE negative, blood test negative. So if children had no antibodies at all at the beginning of the study, they still enjoyed a benefit, but their risk of developing peanut allergy was much lower. It was only 6% if they just avoided peanut. If they consumed peanut, that dropped to 1%. But if you look at this, if they have one or t'other that was positive, and the worst case is if you're on the right-hand side, where your skin prick test was already positive and your IgE positive, as a young infant, and we introduced peanut, we could only get that difference down from 40 to 12%. But appreciate that if a young baby comes to clinic, and I see these kids every week in clinic, and their skin prick test is low positive, sitting back, I really do need to tell parents, a passive approach will give you a 1 in 2 chance of your child being allergic when you come back and your child's a bit older. And if families don't act on this advice, I frequently see the moms come back later, and you can see it on their face. When the skin prick test has grown in size, they are extremely aware that there's a missed opportunity here. And it's sad. I actually have tissues on the table. The moms cry. They realize they've missed this window of opportunity. And increasingly what's happening now is moms will take up this intervention of peanut introduction early, but these kids are so biased towards developing allergies that there are many allergens to eat. And it's very hard in a young infant to give them 12 tree nuts, sesame, peanut, egg, to get this all in early. And occasionally something else will pop up. There'll be a cashew allergy or a walnut allergy. And there's that initial anger, thinking, oh, why didn't we do that as well? So we're still learning how we deal with this whole bucket load of allergies. But certainly for peanut, we can offer people a solution. So the topic is what's new? What's new about the immunological changes? So don't be scared off by these slides if you're not of a science background. They're rather easy to understand. Where you don't want your child to be is in the red-filled star. This is right on the right-hand side is the 6 years of age assessment. The 60-month is 5 years, 2.5 years, 12 months, and those are young infants enrolled on the far left-hand side, 4 to 11 months of age. There are 2 groups. The good group to have been randomized in hindsight, is the green group, the peanut consumption group. The bad group is the gray group. And what you can appreciate immunologically, if you measure skin prick tests, is that if you intervene by feeding a young infant peanut, as a group, they rapidly dissociate. The skin prick tests are far smaller, and that difference seems to expand over time. What else you can appreciate is the difference between 4 to 11 months, a young infant, and 12 months of age. For some of them, it's only 2 or 3 months. If you sit back passively in that gray group, you can see how it rapidly rises. These changes happen very early in life. When the kids come into clinic and they're walking, for many of them it is too late. You want to see your patients when they're sitting, 4 to 6 months of age, very early on. And indeed, my clientele have not, the patients I see have entirely changed. When I first came to the UK, generally patients would come see their allergist 3, 4, 5, 6 years of age. If you come to my clinic this afternoon, you will see young infants. It's amazing how this has changed, and it's extremely reassuring. I get so excited because I can intervene. And in fact, I saved myself this whole discussion by just having a jar of peanut butter right there. And instead of going through a whole long, I quickly take consent and we just get going with it. Day one in the clinic, let's move on. So my practice has certainly changed. What about IgE? So this is the other way you can measure allergy. So this is a peanut IgE test. Now, rather depressingly, you can see these two groups follow each other. They don't rapidly diverge early on. Now, the reason for that is a statistical phenomena that most of these kids were not allergic. So they're all in those bottom zones, and it drags the mean average down. What is reassuring, though, is that you can see that they do split here. So here, children stopped eating peanut in that last year of life. And this suggests that there was some kind of genetic immunological process on the go. They did start separating later on in life. So eating peanut may have influenced your IgE somewhat. There is a different way to look at this. This is slightly complex, but I'll explain it to you. You didn't want to be enrolled in this top row gray zone. So those are leap avoiders. You wanted to be enrolled in the green zone to consume peanut. And this is looking at IgE, the high-level IgEs. And you can rapidly see that that gray mountain grows over time. That if you look at this cohort and you only look at children who had high-level IgEs, there is a significant difference. So consuming peanut will also switch off your high-level IgE in this group. So there's a new finding for you. Now the good antibody, the IgG antibody, this seems to suppress IgE, the bad allergy antibody, is induced through eating peanut. So this looks complex, but what I want you to take home is this green group, the rapid rise and the steep slope of that group. So eating peanut early cranked up IgG. Immunologically, it matters what you feed a child. You may think you can feed a child quinoa and there'll be no immune response. It seems a benign process. But your immune system is sampling these proteins all day long. And if you're lucky enough to make protective antibodies, you'll see that they rapidly go up. Now, many of you are aware of high street tests where people go, and I won't quote their names because you're recording this, but they have IgG tests taken. And they come to me and they say, oh, my milk and my wheat and my egg and my peanut was very high. And I go, fantastic. It's a protective antibody. Let's celebrate. And they look, but the nutritionist said I should avoid these fall. I say, let's toss it in the bin and do some real testing, which people don't like. You have to pay some respect to that. But this is a real antibody. And those assays measure a real antibody. But it's the way you interpret it that is important. And you can see that this protective antibody flies up and continues to fly up. What is a little bit worrying is that at this stage, at 2.5 years of age, you can see it starts drifting down. So these kids are now around 12 years of age. And the question is, what has happened to this protective G4 antibody? Has it just drifted down over time? Will those who were protected now suddenly present with allergies, or will they remain protected? We have not been allowed to use, so this study was published in the NEJM, which is the most rigorous internal medicine journal in the world, and they would not let us use the term tolerance, that we had made these kids tolerant. We could only use sustained unresponsiveness, a technical play on words, but we will now make an assessment at 12 years of age on an additional study in this cohort to see if the benefits are sustained. And then truly we believe that this has protected the kids probably for life. So that's called the LEAP trio ad libitum study. So these kids have been living and eating peanut ad libitum. Those who are allergic have been avoiding. Those who are tolerant have been eating if they want, not eating if they don't want. So we'll have to account for all the different eating patterns and now see these kids that we last saw at 6 years of age. We'll now see them at 12 years of age. And the study is opening for recruitment, hopefully in February, is what keeps me busy every day. And so that'll answer a very important question. So that's something new that you've learned this morning, the LEAP trio study. The ARA-H2 protein, this is that nasty protein. It's a seed storage protein in a peanut that is strongly associated with peanut allergy and with severe peanut allergy, so more severe reactions. You can see that does dissociate between these two groups. It is lower in the green group, which is a good thing, and higher in the avoidance group, which is a bad thing for that group. So that's very reassuring that there's been a shift in that antibody. So I've been talking about this group of proteins, this ARA-H2, these seed storage proteins. So seed storage proteins are complex structures, and they conserve the genetic material of a peanut. So if a cow eats a peanut, it can pass through the tract, still be viable, still grow as a plant. And it is these proteins that cause this nasty variant of peanut allergy. But there are other types of proteins. So I'm going to talk now about this ARA-H8 protein. This is a protein that belongs to the PR10 family. It is found in pollen, and it is found in many foods, including peanut. It is heat labile. So when your child develops hay fever at 6, 7, 8 years of age, and they stop eating fresh tomato, but will still eat cooked tomato or ketchup, that is the reason why. The pollen has made them allergic to the PR10 protein in tomato, and because it's heat labile, they can eat cooked tomato but not fresh tomato. That is known as the oral allergy syndrome, or also called the pollen food syndrome. So I'm showing the study which we published last year. Sian Ludman did this, and she was funded by the UK Anaphylaxis Campaign to do that. So it's a good advert for the research that the campaign is supporting. And what this study showed, and this is new data, is that young children can develop the OAS. We used to think, and I was taught, this only happens in your second decade. Only teenagers are developing this. But children as young as 5 and 6 years of age can develop this fruit aversion because of the pollen allergy that they've developed. Now, in a peanut, very little of a peanut that you eat is the ARA-H8 protein. Most of it is made up by other proteins. And the peanut that we eat in the Western world is usually roasted, so that ARA-H8 is slightly damaged. But the LEAP study does really allow us to look at whether eating peanut early will suppress this form of peanut allergy. So when you eat peanut, you are eating that PR10 family, which is related to the ARA-H8 protein sensitivity. And what do you notice? So this is new data, and I find it extremely interesting. So these two groups match each other. Although those lines look different, there's statistically no difference between them. So if you eat peanut early, you can suppress your allergy to seed storage proteins, but not suppress your allergy to these ARA-H8 pollen-like proteins. So that's a new finding, and it speaks to mechanisms. It's not very helpful because you're not able to prevent this variant of allergy. What we know that those who are birch sensitized, so if you look at this group, so these guys they're sensitive to birch pollen, and when you look at their mean ARA-H8 level, you can see it's extremely high. So where you find birch sensitization, you will find the oral allergy syndrome, and that can occur to peanut, particularly raw peanuts, which luckily we don't eat a lot of. Now, birch pollen sensitization is very high in the UK, and I'll show you some data in a second. It can also happen if you are grass pollen allergic. Here is a new paper. This is out just last week. It's still in press. So the question is, if feeding peanut to young kids is so effective at preventing peanut allergy, does it make a dot of difference on any other allergic disease? Have you somehow developed these T regulatory cells, these good protective cells that will stop you from developing hay fever or asthma? Well, if you look at eczema in the LEAP study, so again, where you want your child to be is in the white columns, in the white blocks of the white columns. The very left is the avoidance group, then the consumption group, and you go across time periods. And what you can see, which is what you all know, is as children get older, more and more will not have a positive scorer. They'll be in the negative scorer range, which means that their eczema is going away. But rather depressingly, you can see it makes no difference if you ate peanut or not. Eating peanut will not affect your rate of eczema resolution. What about rhinitis, hay fever, and asthma? Well, let's look in the middle column, seasonal allergic rhinitis, at 2.5 years, 5 years, and 6 years of age. Again, you can see in both groups this rapidly rises, so much so that 1 in 2 children has this condition. And we used very strict a priori criteria to measure this, and eating peanut makes absolutely no difference. What if you look at aeroallergen sensitization? So look at the second column where you see birch, that these rates rapidly go up. And again, it makes no difference if you were eating peanut or not. So this appears disease specific. It only affects peanut allergy, not these other allergic diseases. Your egg allergy or sensitization will resolve as you get older. That is normal in children. Again, it makes no difference if you eat peanut or not. Now, this is interesting. The only significant difference you can see here has got the asterisk on it, and that is for peanut. We know we made a difference looking at peanut allergy. If we look at the allergy tests, IgE and skin prick tests, to the other tree nuts, Brazil, walnut, cashew, almond, sesame, as well as milk, hazel, and egg, have we shifted any other allergies? And you can see there is no difference. This is a bit like the meningococcal vaccine. Many of you know you had to take your children to get a top-up with different strains. Covering against one strain will not protect you against another. The immune system sees these allergens as specific and unique. When we use a different cutoff, we do see differences in walnut. You can see where that is starred, and cashew nut, almond, and Brazil. The top group is in the intention to treat group. That's everyone we intended to treat. Not everyone ate peanut and did as we said in that group. The bottom group, the bottom row, is in the per protocol group. All these children either avoided or consumed. And you can see that that effect, those differences that may have been related to eating peanut, then fall away when you look at those who actually did eat peanut. So we do not believe, we published this because it's scientifically the right thing to do, but we do not believe that eating peanut increases sensitization to other allergens. And this is a safety signal we were looking at. So this is the final slide of the LEAP study. I know you guys are looking tired. A lot of science. Basically, what I wanted to show is if you look at the Venn in the top left, that's the avoidance group, the Venn in the top right. Even though the study was so successful at reducing peanut allergy, have we made a difference when you put all your allergic diseases together and when you consider likely food allergy as a skin prick test to all the foods we tested to? And the answer is no. The kids are equally allergic in both groups at the end of the LEAP study, sadly so, although one group has far less peanut allergy than the other group. So what does this teach us scientifically? Well, it teaches us that if we're to deal with this whole burden that allergic kids have to live with, we're going to need other interventions or multi-pronged interventions. It may be that we need to feed 15 common food allergens very early on in life if we're going to prevent children developing this huge burden of allergic disease. Does this work to other allergens? Well, luckily, Bob Boyle and his group have just done this review, and you can see, so this is a forest plot. So you want everything to fall to the left of this risk ratio, of this central dotted line, to show that you are decreasing the risk of food allergy. First up, Bob looked at egg allergy, and the Perkin study is the EAT study, also done at our center with Gideon Lack and Michael Perkin. LEAP was obviously only done to peanut, and there are some studies that looked at milk. And you can see that the effect is, when you pile all the data we have from randomized controlled trials, the effect is strongest just for peanut. This falls well to the left. For egg, there appears to be a signal. For milk, this crosses the midline. And so we're not certain whether consuming milk early is going to protect you from milk allergy in life, or consuming milk protein. So we see an effect for egg and peanut. So to say you should eat 15 allergens is only proven for 2 of them so far before we put that out as a public message. The other important lesson we learned from the EAT study is it's actually quite hard to feed numerous food allergens to young infants when they're weaning. So if you look at the uptake, the percentage per protocol adherence, people who could follow what we asked them to do with regards to consumption when kids were very young and breastfed. For milk, it's easy. For many reasons. People are familiar with milk. They can take yogurt out the fridge and add this to foods, and the baby will swallow it easily. It's easy to swallow. For peanut, remarkably, 70% of people could introduce peanut early. So smooth peanut butter or Bamba melted down, which is a sort of peanutty snack, is quite an easy thing to do. Things then start falling off. Fish is harder. Mom has to cook the fish. She's exhausted. She hasn't slept for 8 nights. And then you've got to cool it down and it's more difficult to eat when you're just starting to eat foods. For sesame, well, Brits aren't that familiar with tahini. It's a sort of Middle Eastern cuisine goo that not everyone takes to. And so sesame uptake was lower. Egg, well, it takes mom a fair amount of time to boil an egg, 12 minutes, and another 10 minutes to cool it down, another 3 minutes to chop it up, and then to try and coerce your young allergic kid to eat egg. You can see is not many people could follow what was asked of them. And bread the wheat did so poorly because it was introduced last. So there's a different reason for wheat doing poorly. So the take-home message from this slide is that, yes, in time, in the next decade or two, our weaning guidelines will change yet further. But what people can practically do has limitations as well. So I had a question earlier about translating these trial findings into the real world. What recommendations? So this is one of our little kids eating some peanut early on in the trial. So you can see the United States government has adopted our findings, and they now recommend that in a low-risk scenario, all children should eat peanut early, have it introduced earlier into their diet, in accordance with family and cultural practices, they say. Where there is some risk, they ask for you first to be assessed, have an allergy assessment. Now, there's a problem with that. There are so many at-risk infants in the world, and so few allergists and services, that doesn't always work out, but it's a good precautionary statement. So children are now eating peanut early and recommended to do so in the United States. This is adopted by all their major societies, their Paediatric Society as well. What's happening in Australia? Well, they didn't go down the get tested route. They said, when your infant is ready at around 6 months, but not before 4 months, start introducing a variety of solid foods. All infants should be given allergenic solid foods, including peanut butter, cooked egg, dairy, and wheat products in the first year of life. This includes infants at high risk of allergy. So they're not saying get tested. And then they say that infant formulas won't save you. So the Aussies have adopted a more relaxed approach. The Americans a slightly more stricter, governed approach. And it'll be very interesting to see how that pans out as a public health intervention over the next year or two. What's happening in the UK? So the Committee on Toxicity, COT, which last put out a statement in '99 about how you should wean your kids, or then it was not wean your kids onto allergens. So you may wait a long time before these change. This year have put out a joint statement. And what do they say? Advice on complementary feeding should state that foods containing peanut and hen's egg need not be differentiated from other complementary foods. So it takes away the stigma of these two foods in amongst baby rice, courgette, and butternut squash. Complementary food should be introduced in an age-appropriate form, so obviously the kid must be able to swallow it, from around 6 months of age. This could be 4, 5, or 6 months, preferably alongside breastfeeding. Breastfeeding is brilliant, but as an allergy intervention, protective intervention, I'm not sure there's huge data to support that, but it's healthy for a million other reasons. So I'm happy to see it there. The deliberate exclusion of peanut or hen's egg beyond 6 to 12 months of age may increase the risk of food allergy to some foods. So it takes a pretty laid-back approach early on, and then now says, whoa, well, don't hold back with this. So it's a bit more proactive there. If initial exposure is not continued as part of the infant's usual diet, then this may increase the risk of sensitization. I'm not sure why that's in there. The evidence is not huge for that, but it encourages ongoing consumption on a healthy food. Families of infants with a history of early onset eczema, so that's about 15–20% of the UK population, that's a lot of children, or suspected food allergy. So what is suspected food allergy? That's a bit difficult. May wish is a bit vague. May wish to seek medical advice before introducing these foods. So that's probably not the greatest statement, but this is what's out there. So my final slide. We're talking about feeding a healthy food to young kids. Peanut is full of healthy fat and low in sugar, which is the way dietary guidelines are going now. Fat is back. It's not this demon as we all were trained in over the last decade or two. And kids are encouraged to eat healthier fat diets that are low in sugar, which is extremely hard to do. But you can see that in the LEAP study, if you ate, and we fed them a lot of peanut, if you eat a lot of peanut or not, you will have the same growth after 5 years. We were not undernourishing or overnourishing either group. It is feasible. People can do this. It's easy. No one choked on this if you avoid whole peanuts, obviously. People ate more than what we asked them to, and they ate it for 5 years. If you look at the nutrition, this supports the protein homeostasis theory. So if you try and feed many animals as much food offer them as much food as you possibly can, generally animals will start regulating themselves. What happens with your children? If you keep trying to feed your kid, eventually they will stop eating. And people aren't entirely sure in humans what does that. Is it the protein in that meal, the fat, or the carbohydrate that induces satiation? And more, certainly in bears and cockroaches, we know this to be protein. that when you reach a level of protein in your diet, you will be satiated and you will stop eating and regulate your diet around that. Now, the problem is protein comes either with a lot of sugar or a lot of fat, so it depends how you come across that protein. But in this group, we were pleased to see that children eating peanuts snacked less on other rubbishy food, particularly fizzy drinks. So forget about allergy. Peanut allergy affects only 2% of the population, 2 or 3%. Obesity affects some 30% of the population. So this is a healthy intervention, and we now, in the LEAP Trio study, we'll also look at other nutritional outcomes. Is this good for many other reasons besides just allergy prevention? And finally, the way forward with prevention. I've only spoken about eating peanut and egg, and we're still trialing other foods. There are many other interventions now being trialed. The SEAL study will look at sealing the skin barrier aggressively and early on in life. People are very keen on adding probiotics to these interventions, and there probably are other interventions being trialed at the moment. So things are developing as we speak. Just some thank yous to all these organizations that supported our research, and of course to our lovely young patients that were on the trial. Thank you very much.
Thank you. With the understanding now that eggs can not have salmonella in anymore, can we think about giving kids eggs in a slightly more edible form?
It's a good question. So hard boiling an egg brings about an aroma and a firmer texture that may not be appealing to young kids, and that's one of the reasons maybe it didn't have such great acceptability on the EAT study. Salmonella on a 3-line egg is no longer a risk, so that's why people were told not to feed raw eggs to the children. The only snag with raw egg allergy is if you're going to be allergic, it's highly allergenic. So egg is a structural protein, the allergen. So the more raw and fresh the egg, the more intact the structure, the more allergenic it is. The more you cook an egg, the more unhealthy egg protein is, like a biscuit cake muffin, which you're not going to wean a child onto, but the protein is significantly damaged. So yes, you may get greater acceptability if you just do a soft-boiled egg as opposed to a very hard-boiled egg. But if the kiddie does have eczema and other risk factors for egg allergy, you just need to be cautious in that setting. And in the Australian study, in Susan Prescott's study, the study was stopped because of severe reactions to raw egg. Quite a few of the egg trials have tried to use undercooked egg. It was just pasteurized egg, which is not very processed. It was a powder, and it is highly allergenic, and they had significant reactions on those trials. So it's sort of risk-benefit, Hazel. You may get it into more kids, which is a good thing, but you may have more significant reactions as you move towards raw egg protein. Powdered egg. It just depends on how much it's heated. You can have intact egg protein still in a powdered form. It takes a lot of heat to significantly damage the protein.
So my understanding is that the PR10 is more relevant with developing the birch protein. Is that right?
Yes. So the classic form of peanut allergy you develop either through the root or through your skin or your first consumption. What happens with this oral allergy syndrome is you develop your birch pollen allergy first through your respiratory tract. You then develop proteins to the PR10 family in birch that is near identical to peanut. So it's funny, it's a pollen making you food allergic, and it comes on a little bit later in life.
Thank you.
And eating it sadly doesn't seem to make a difference, eating it early in life, as it did for the other variant of peanut allergy. Many parents aren't aware of this, so they raise a kid who's got 2 or 3 allergies, who's a little bit fussy because of that, and they eat stone fruit, apple, peaches, pear, cherries, carrots, quite happily, celery, foods like that. Then as they get older, they become fussy with all these foods. They'll still have ketchup, bolognese, tomato sauce, but they won't go near raw tomato, and the parents sometimes get quite angry with them. Or they grow up eating apples quite happily, and then as they get older, they start asking for this apple to be peeled, because most of those PR10 proteins are in the peel, and they still eat that. Then ultimately they go off the pulp of the apple, but they're still eating and drinking apple juice, apple pie, tart. So when it's heat processed, they still tolerate it. And it's quite funny dynamic in clinic, because the parents have got angry with the kids saying you're fussy and it's just an apple and you used to eat that and you're allergic to peanut, yes, but eat your apple. And it's a strange dynamic because it creeps up on you with time. So it's important that families actually know about this, because you also stop trusting your kid. You think your kid moans about every food. And I see this in food challenges a lot. It's, so we do lots of, mainly peanut challenges, but other foods as well, that the kids very early on complain of a fuzzy, spiky, metallic sensation in their mouth. I don't like this. This doesn't feel good. But mom knows their kid's anxious. They're sitting in hospital. We've just cannulated them. There's a whole dynamic around that. And it's important that you can trust your child and they can trust their own symptoms, their own mild, obviously obvious symptoms, everyone knows what's going on, but it's the mildest symptoms, and those are very common in the oral allergy syndrome. Severe reactions can also start with mild symptoms, so that's what's confusing and scary as a parent. 1 or 2 hives and a bit of spikiness in the mouth either goes on to anaphylaxis or mostly never does and just remains mild, and you only know when you know. So there's a whole dynamic about trying to learn what your child is, learn about what your child is describing.
And you still expect to see high IgE on the bloods?
Yes.
Against peanuts?
Correct. And if people don't understand this, so if somebody just does a peanut IgE, that peanut IgE is done to RH1, 2, 3, 8, and 9. It will be positive. So unless you go and look for all those cofactors, if it falls into the wrong person's hand, they'll just say, you're peanut allergic, you must stay away from peanut, you do need an EpiPen. And it may just be that later onset variant and not the classic peanut allergy. So that keeps a kid safe, that overreaction, but it means a life of avoidance, something you may not have had to have avoided. And you don't need to carry, you know, adrenaline auto-injectors for that condition.
So want to request the PR10 in somebody?
Sure you can, in an older kid who presents with that sort of phenotype. But in the young, typical scenario where a child has had peanut butter, you know, first 5 years of life and had a significant reaction, it's not worth doing because they've got the first variant, yeah. But in the older kid who used to eat peanut and now goes off it and complains about a little swollen lip and a funny sensation in their mouth or some gut pain after eating peanut, who's riddled with hay fever, particularly during the birch season, then you could ask for that test if you want, or clinically you can just diagnose it without the test.
I work in a London borough and we deliver a healthy eating programme aimed at a range of early years providers. So we work with playgroups, children's centres, childminders, work with a dietitian on this. And one of the biggest challenges we're having is that a lot of parents of children 3 months of age, 6 months, a year, are actually eliminating lots of foods from their children's diets. And they're asking the nursery as well not to give these foods to the child. They haven't been exposed to lots of foods during weaning as well. And I just wondered what your experience or what your view on that was.
It's extremely difficult because we want a message to go out that food allergy is serious, that we need to act on it, that these nurseries, creches, feeding programs need to take it very seriously. But equally, we want the message to go out that the majority of the population is not food allergic, that food allergens are otherwise healthy foods, good to eat early, protective if you eat it early. So it's a very fine balance that takes a little bit of insight, hence days like this really, to try and get the message across. And it has to get to parents as well. You know, parents are really, some of them are really scared about certain food allergens. Ultimately, you need access to decent testing. With decent testing, hopefully, you know, all this can be answered for you.
Thank you for your excellent talk, very insightful. It focuses very much on younger children. And my question is, what about teens and adolescents? Do you have any insights on desensitization and outgrowing allergies for the older children?
So what I've spoken about this morning is the prevention of food allergy, the treatment of food allergy. You may have it covered later on in the program. It's a whole kind of different topic. But so the first case study in the Lancet was in 1908 about egg desensitization. Is that me? So this has been around for a while. But you've got to ask yourself, why hasn't everyone been doing it? Why isn't it commonplace? So either it hasn't worked or it hasn't been safe or acceptable to patients and families. That's changing a bit now because there are many studies that have come out now, mainly to peanut, but increasingly to other food allergens, looking at giving known allergics small increments. And Aimune is a commercial company looking at that. There are others who've tried it using just other forms of peanut. And it's extremely exciting to be involved in those programs. A very emotional program. You take kids from being highly allergic to very small amounts to being able to tolerate larger amounts. And hopefully this will move outside of the research setting pretty soon, within the next few years, and be accessible to many more people.
Via NHS?
we'd obviously hope that it gets licensed in NHS. It's been very hard getting pollen immunotherapy paid for in the NHS. Some forms are, so that's going to be an ongoing struggle, but that's always our goal. I mean, the NHS is our health service.